Good morning and welcome to the Health and Social Care Alliance's lecture being delivered by Professor Derek Feeley. The title of our lecture today is Shaping the Future of Health and Social Care. And I will introduce Professor Feeley shortly. Before I do so, I would like to extend a very warm welcome to all of you who are joining us for today's lecture or joining us by listening to the recording. So today's lecture is part of the lead up to our annual conference being held on the 1st of May. The conference this year is titled Our Voice, Our Rights, Our Future. Our ambition for the conference is to provide a focal point for discussion and deliberation around some of the big challenges facing our health and well-being and facing our health and social care system. Our intention, though, is not just to focus on the challenges, but to encourage through that discussion an opportunity to draw out some of those solutions and our shared ambitions, and really to encourage a sense of hope and ambition for the future. Because the evidence, both what we know and what we feel, all highlight that our health and well-being is not in a good shape. And although many of the causes of that lie out with the health and social care system, the health and social care system does enjoy a significant investment from our public spend, the numbers of of society who work within the health and social care system, and it really does need to be fit for the needs of today and future generations. At the same time, we are continuously hearing that the economy and our public finances are also not in a state of good health. And this means that there are pressing and difficult decisions which need to be taken. The Alliance has been working to support the transformation of health and social care for almost 20 years, informed by our members. And yet, despite many pieces of legislation and many strategies, I would suggest that lots of people who are accessing health and social care services, possibly also people working in health and social care, would still feel them to be pretty similar to how they looked generations ago. I recall hearing Professor Feeley when he was Director General of Health and Social Care and the Chief Executive of the NHS, saying that in times of crisis, it's really important that we don't waste those opportunities that these offer for us to make significant change. And the Alliance is committed to continuing to work towards helping to realise some of those changes which are needed. So today's lecture holds particular significance for us, particularly in the lead up to our annual conference, where Professor Feeley will be exploring some of those challenges, but also some of those opportunities facing health and social care. So to introduce Professor Derek Feeley, Derek is a Senior Fellow at IHI, the Institute of Healthcare Improvement. He's also currently a board member of the Institute for Research and Innovation in Social Services, an advisor to the board at East London Foundation Trust, and an honorary professor at the University of the West of Scotland. Importantly, he also chaired the Independent Review of Adult Social Care, which reported to Scottish Government in 2021. And before returning to Scotland was the IHI's Chief Executive. And before that, and as I mentioned previously, has been the Chief Executive of the NHS for Scotland and Director General of Health and Social Care at the Scottish Government. So, Derek, I am really, really pleased to be welcoming you to this lecture. And as I was saying before others joined, really interested in what you're going to be sharing with us today. So I shall hand over to you.
Thanks, Sarah. And while we're getting the slides up, a couple of things. I suspect your recollection is correct. Never waste a good crisis is probably something I said. But the second comment I wanted to make was really about the Alliance. So as someone who was around nearly 20 years ago when we set up the Self-Management Fund, to see how far the Alliance has come over that period just kind of fills me with joy. It's the maturing of the organisation has been lovely to watch. And I often say, it was a relatively small investment we made at the time in the Self-Management Fund. It's a couple of £1 million from memory. And I often say it's the best investment we ever made. There's no way that people sitting in St Andrew's House could have done half the things that the Alliance and its partners have been able to achieve. So before we get into the meat of the presentation, if you like, I just wanted to offer those reflections. All right, so here we go. We're going to. I really like this slide. This quote is attributed to many people, but I've used Niels Bohr here. I'm not going to try and make any predictions. This is not me having any kind of deep insight into the future. What I'm going to be able to offer you, I think, is just some thoughts on a direction of travel that that might take us to a better place. One of the things that Sarah said in her introductory remarks about the Alliance is that one of its functions is to bring hope. And that, I think, is one of the things that we need right now. We need a view of the future that's more attractive than the status quo. And that's what I'm going to try and sketch out. The other thing just to bear in mind is, well, because we're talking about the future, there's very little evidence. And because we're going to talk about innovations and maybe even transformations that need to be made, there's even less evidence. And so I don't like operating in an evidence light zone, but that's where we are. So just accept it as that. These are my reflections. It's an N of 1. And I hope I at least say something that has some kind of resonance for you. And then finally, forgive the cold. I apologise particularly to David and in turn to Linda. I'm hard enough to understand with this Fife accent, but with the cold as well, it's going to be challenging for you. Anyway, let's go to the next slide. And this is really where I want to start for two reasons. Firstly, I think with all due humility, it's a good place to start. It's mainly a good place to start because almost every word that's in that report came from people with lived experience. There's very little original thought in there. It's mainly the perspectives of people who need social care support, who generously and kindly offered their insights, their lived experience. And the second reason I think it's good to start here is we rarely start with social care and ask, so what for healthcare? And I think it's about time we did. So we carried out this independent review. If you go to the next slide, please, right in the middle of COVID. And actually that turned out to be one of the few silver linings that came with the COVID cloud. Because what it meant we could do was reach many, many more people than we would have been able to do in any kind of face-to-face engagement. And it also, I think, created a bit more of a safe space for people to really offer their opinions and perspectives. People who perhaps wouldn't have spoken up in a large face-to-face meeting could do so on the chat or felt safer in the comfort of their own home to offer us some kind of perspective. But we got a huge amount of input, much of it facilitated incidentally by the Alliance. And then we had this open call for submissions. We got over 200 of those. We encouraged people to have their own meetings and just feed into us. And we had a basic engagement rule, which was refuse no meeting. So if anybody wanted to talk to us about the future of social care in Scotland, they were able to do so, and many took that opportunity. The next slide just gives you some sense of what we heard. You can see in the report, as I said, threaded through every bit of the report what we heard. But this is my basic summary in 4 bullet points of what people told us. Firstly, they wanted to be heard, and they felt that previously their voices hadn't really been heard. They hadn't been understood. People perhaps had been listening to them, but listening to respond, not to understand. And so people wanted to be heard. Second, people saw social care as a human rights issue, and they wanted those rights to be honoured by people who had power in the system. Thirdly, they wanted pretty much everything made easier. That went from the process of accessing and being assessed for social care support all the way through to just the activities of daily living. One person described the assessment process for social care support as brutal. And that's not how it should feel. It should feel supportive and as I say, just easier. So people wanted us to make it easier for them. And then fourth and finally, people wanted to be seen not as a problem, but as potentially part of the solution. In the kind of truest sense of co-design and co-production. There's been a lot of loose talk in the progress of the National Care Service bill about co-design and co-production. We'll maybe come to some of that in the Q&A later. But this was co-design and co-production seen from the perspective of the person who had a right to some support. Next slide, please. So here's what we recommended. 3 things really. Just firstly, a new narrative. So a new way to think about social care support and how we represented it in the kind of public discourse. Secondly, a recognition that there was actually quite a lot of good ideas and good policy around social care support, but much of it poorly implemented. And so we recommended the strengthening of those foundations. And thirdly, we recommended a redesign of the system. That's where this idea of a national care service came from. But there was more to it than that. And again, we'll come to that. So, but let's start with a new narrative in the next slide. People were tired of hearing that social care support is a burden on society. And so we wanted to flip that round and help them to see that social care support's an investment in a good society. I don't just mean in economic terms. However, there's no question that investing in social care is a good investment in economic terms. I'm speaking here as a lapsed economist. I can't claim to be an active economist any longer, but there are plenty of studies, for example, around the Independent Living Fund that shows something like a 14-to-1 return on investment from the Independent Living Fund. You don't get that very often. Work that's been done that compared an investment in social care with an investment in construction that showed you get twice as much social benefit from an investment in social care. Spending more money on social care is a good investment. And we need to stop talking about it as if it's some kind of burden on society, but that's still, I'm afraid, the prevailing narrative. And then I'm not going to go through each of those lines line by line, but you can see some of the kind of sense of it, moving away from thinking about social care as about managing people's needs to enabling their rights and their capabilities, so taking a more assets-based approach, trying to intervene and support people's lives earlier, so that it doesn't just become something that's available in a crisis, and removing some of the variability in people's experiences, so that no matter where you were in Scotland, you could have some kind of predictable path to getting the support that you needed. And unfortunately, that's not what we saw. We saw huge and often unwarranted variation in the level of support that was available to people, and whether or not they were charged for that support, etc., etc. So a new narrative was the first thing, and in my view, this was the most important of our recommendations, because unless we start to think differently about social care and social care support, we're not going to be able to successfully redesign it. We're going to impose better designs on a basically bad system. Second set of recommendations around these gaps that we saw. Gaps in the extent to which people felt valued, that's what I mean by the pay gap. Gaps in the level of power that people held in the system compared to what would be best to enable everybody to make a contribution, and the implementation gap to which I referred earlier. Self-directed support's a great example of the implementation gap. It's the kind of fundamental, or ought to be one of the fundamental building blocks of our system of social care support. And yet only about half the people who might want to utilise self-directed support get the opportunity to do that. So some great stuff in our existing system, and some barriers for people to overcome, some gaps that we had to leap in order to get to that better place. And then the third set of recommendations were really about, if we go to the next slide, about the nature of the system itself. This idea that maybe there's just a wee lag on the slides. I can more or less remember what's in it. And this is where the idea of a national care service came from. The next slide, I'll explain why we said that, but you would be forgiven for thinking that this was the only, and that the creating of a national care service was the only recommendation that we made about how to change the system. And it wasn't. And some of these other things are also really, really important. If you go back one, please, just for the time being. The idea that we should rethink commissioning. That if there was one thing that everybody agreed on that we spoke to, was that commissioning wasn't working for anybody. It wasn't working for the providers, and it certainly wasn't working for people who needed support. The idea that we needed to amplify the voice of lived experience at every single level of the system, not just where the service user meets the social care worker, but at the level of the integrated joint board. And if we have a national care service, at the level of the National Care Service Board, that voice needs to be heard throughout the system. That we should stop thinking about social care that has anything at all to do with profit, and start to think about it as something that is designed for the public good. That's partly where our notions about ethical commissioning came from. And fundamentally, we saw social care as about relationships, not in about transactions, not in 15-minute visits, but in people feeling a sense of being supported. Most of those things we could do now. They don't have to wait for the National Care Service. But some things, I believe, will be improved and accelerated if we had a National Care Service. And in this next slide, I try and outline some of those things. Firstly, it would just be clearer about who is accountable. And I think one of the things that COVID showed us was that in a crisis, people hold Scottish ministers to account for what happens in social care. You just have to think about outbreaks of COVID in care homes and who was in front of the TV cameras. It was Scottish ministers, and I think rightly so. But they are not technically accountable. I was as Sarah said, I used to be the Director General for Health and Social Care. And I was accountable in the Parliament for every penny we spent on healthcare. And I felt accountable, and again, rightly so, for every penny we spent on healthcare. No one ever held me to account for social care budgets, ever. So clarifying, strengthening accountability, a reason why we need a National Care Service. This idea that, which is kind of where I started, that social care and healthcare ought to be on a level playing field. And having some kind of national integration between health and social care ought to be helpful. A national care service ought to be able to tackle what people describe to us as the postcode lottery. That some things were available in some parts of the country, but not in others. Some things were charged for in some parts of the country, but not in others. A national service can and should be able to tackle these kind of things. Our current organisation of social care gives us no means to scale up good ideas. I remember vividly a conversation I had with one third sector organisations who described a really innovative and results generating intervention that they had made for people with early stage dementia that kept them out of a facility and kept them in their home. They've proven that it worked in 2 or 3 local authority areas, and I asked them about, well, how are we going to get that nationally? And he said, I have to go and sell it to 29 other local authorities. Well, that's never going to work. And so we need somebody who is responsible for identifying good practice and bringing it to everybody, not just to a few. And then we need some kind of vehicle to close those gaps that I talked about earlier. So there are some days where, frankly, I regret ever putting a national care service in the report, because it's where all of the energy has gone. And if I wrote the report again tomorrow, I'd still recommend a national care service. I hope that those 2 things are not too contradictory for you. Next slide, please. All right, so let's think then about what are the implications for healthcare that come out of, again, if you just go back 1, please, that would be great. Let's think about some of the implications for healthcare of those conclusions that we reached from that analysis of where we needed to go around social care. I think we need a new narrative for healthcare too. This idea, we think about healthcare, these are Nigel Crisp's words, we think about healthcare as a repair shop. And we ought to think about it as something that is preventative and anticipatory. And I know those words have been used again and again. I remember talking in the care report. When was that? 2004, maybe. about prevention and anticipation and shifting the balance of power. And it seems we've made some progress, but not enough. And so we need to get back, I think, to those that underpinning narrative about what is our NHS for, and can we make it more about the creation of health and less about repair. Some people will like this next bullet point and some won't. I am beginning to think that this notion that we ought to be patient-centred is unhelpful rather than helpful. And it's more helpful, I think, to think about patients as partners. That's what the people who wanted us to hear their voice were asking. They wanted to be partners in their social care. Because I think too often patient-centred ends up meaning that the professionals collaborate with each other around the patient. And they do that in a very well-meaning and thoughtful kind of way, but I don't think that's what those people who needed social care support were telling us, and I don't think it's what many patients want either. They want to be true partners, not to be collaborated around. Just as social care in the future is going to need unprecedented collaboration, this idea of some kind of split between the purchaser and the provider and the recipient of care is unhelpful. So we're going to have to rethink the nature of collaboration in healthcare. And finally, just as there are inequities and unfairness in our social care system and its outcomes, so too does that exist in healthcare. And so we need to make sure that we tackle that. So he said, eventually getting to the point. What is it that we need to see then for health and social care if we think holistically across the two? And this next slide gives me a framework around which to hang some of those things. So I think there are some moral imperatives. Three things I think that just we have to do because it's morally right to do them. Then one of the things that I learned as I did the social care work, and I see every day in my work in healthcare, is that we need to invest in our people, in our staff. And that maybe feels a little bit, to those of you who come at this from a service user, I don't like that word, or a patient, I don't particularly like that word either, or a person who just needs some health or social care support. That maybe seems like the wrong way to come at this, but I'll explain why I think it's important in a minute. And then I think we need three kinds of radical thinking, and I mean radical. So let's start with those three moral imperatives. The first one on the next slide is equity. As you can see, many people will have seen this next slide before. It's the subway map. And you can see the difference in life expectancy from Bridgeton there to leafy Jordan Hill. Something like a 14-year gap in life expectancy for men in those two geographies. It's always, we've known about this for, oh goodness knows how long. In this kind of detail, at least 20 years, maybe 30 years. It's time to do something about it. I think we can no longer accept a system that delivers these kind of outcomes. There's an old phrase we use in the improvement world, which is every system is perfectly designed to get the results it gets. And I'm sorry to say that, and I say this as someone who has been at times responsible for this system. I'm sorry to say that our system design delivers this. So that's our first, I think, the first of our moral imperatives. As we think about what are we going to do next, we should think about it through an equity lens. I think the second lens is about human rights. This was one of my big learnings from doing the social care work, and I think it applies every bit as much in healthcare. And it's time that we recognise that people have rights. It's time that we enabled those rights to lead to better outcomes for them. And all they're asking for is some simple things like participation and engagement, and not to be discriminated against, and an opportunity to live an independent life. People are not asking for the sun, the moon, and the stars. Just for us to recognise their human rights and act in a way that might help them fulfil those. So that needs to be right at the very centre of our redesign. And the third thing is civility. I think we have just lost some of this. This is research from Australia, but it's not any different here. Loads of people at work are experiencing these things. It's not just a healthcare thing; it's a social care thing. And for goodness sake, can we not just be a little bit more respectful and civil? Again, it's not asking for much, I don't think. But those are, before we get into the nature of the transformation that we might want to make, those three things just felt morally right to me, for us to recognise that whatever we do, let's do it with equity in mind, let's do it with human rights in mind, and let's do it with civility in mind. Let's respect each other's perspectives. I don't know, maybe it's just me and I'm getting old, but the world seems more polarised than it used to be. And we can and should disagree about stuff, because that's where ideas come from. And conflict is inevitable, and I think properly managed ought to be encouraged. But that doesn't mean that we can't do that in a civil way, in a respectful way. So 3 moral imperatives, that's the first. Then there's this idea of what I call joy in work. That, I think, is what our staff deserve, is to have a sense of joy in their work. And by that, I mean more than just not feel quite as burned out as they currently feel. This next slide, if you bring it up, is how people very often react when I talk about joy in work. When we first started to have these conversations, you could actually see people cringe, because there's just such a big gap between how they currently feel and any sense of joy. But I think it's really, really important. Why is it important? Well, I'll start to explore that in the next slide. This is a survey done by Natasha Smallwood and her colleagues of the prevalence of mental illness in the healthcare workforce. That, again, I think there's no reason for us to think it's radically different in the social care workforce. In the healthcare workforce during the pandemic. And the blue lines are people's self-reported outcomes and the orange lines are use validated tools to assess the prevalence of mental illness in the workforce. And if you look at that, using validated tools, 70% of the healthcare workforce are burned out. 40% have signs of PTSD. Where would you see typically people suffering from PTSD? Following conflict and war. So that's how it feels to people who are working in health and social care just now. How can we expect people who feel like that to do some of the things that we're asking them to do, to support people in the way we're asking them to support them? And so that is one of the reasons why I think we need to tackle this. It needs to be part of our strategy moving forward in investing. Jen, her name was Natasha Smallwood. And it's published, so you can easily look it up. Let's go to the next slide. This is why I worry particularly about burnout. People often confuse stress and burnout. Burnout's much more damaging than stress. It leads to people being disengaged when we need them to be engaged. It leads to them feeling detached when we need them to be partners. It tends to lead to their emotions being blunted when we need them to feel something and to care. So it's a really important thing for us to tackle. Next slide, please. And as I said, this is really important from the perspective of the person receiving care or receiving support as well. Because as this survey shows, practitioners who are burned out make mistakes. If I was still responsible for patient safety in Scotland, the number one thing I would do is invest in the clinical workforce to try and reduce burnout. It's the best intervention we can make to improve outcomes for patients and their families. And we know what to do. I've been working with IHI mainly in Australia, but also in other bits of the world. And we have been applying this methodology, a simple 4-step process. And then if you go to the next slide, which shows you a set of interventions that are required of senior leaders, of managers, and of every single one of us. It really is achieving results. It's reversing the trend of burnout. It's showing a relationship between increasing joy in work and reducing burnout. This is, again, I'm conscious that the previous bit was a bit kind of, this is a crisis, but we have got interventions that can make a difference. We just need to deploy them. All right, let's get to the third set of things, which is really about that radical thinking. And I said there's kind of 3 sets of radical thinking that we need to undertake, I think. And there's no one thing. I think that's I see lots of people kind of chasing this. You know, what's the people often ask me this actually, Derek, what's the one thing I could do? And my response to that is always the same, which is the one thing you could do is stop thinking there's just one thing. Because so complex is the situation that we find ourselves in, we're going to have to address multiple things. There's no miracle, there's no magic. But there are, I think, some opportunities. Let's try and explore what those are. Next slide, please. First thing is, and I hope everybody would agree with this, that I'm pretty sure the answer is not just more of the same. The sailing vessel on the right-hand side of that slide there is called the Thomas W. Lawson. It was the world's first 7-masted schooner. And it was the designers of the Thomas W. Lawson were responding to the coming of the steamship. And their answer to it was more sail. Well, it turns out that 7 masts on a schooner are inherently unstable, and Thomas W. Lawson ran aground on its maiden voyage. The answer to the coming of steam wasn't more of the same, and the answers to our problems are not more of the same. And so if it's something different, what might that be? Let's go to the next slide. And I think this is, and this is back to where Sarah started us, I think this is the time for revolution. And this is the opportunity that presents itself. These kind of paradigm shifts that Thomas Kuhn describes in this book only come about because of crisis. Because something in the current way of that we organize our world doesn't work. And so we have this kind of opportunity to completely rethink and create this new normal, this new paradigm. And that, I think, is the opportunity that we should take. We'll not get many of these opportunities. So let's try and take this one. Next slide, please. There's a lot, I get a lot of people talking to me about transformation, and most of them don't really mean transformation. So I hope we can agree on this call that we really do want some kind of complete change in form. It will need some real changes. Next one, please. So here's my starter for 10. This is all. The one thing I will say about this slide is, well, 2 things I'll say. Firstly, it's just mine, as I said at the start. And the second thing I'll say is it's almost certainly wrong. And all I would like you to do with this, if you would consider it, is just think about what your list might look like. And let's have a conversation. So home first. I think, look, again, as I said earlier, we've been talking about shifting the balance of care for 20 years. Have we really shifted the balance of care? No, not really. And I wonder whether one of the reasons for that is we talk about shifting it into the community. And maybe that's too timid. Most people, when you talk to them, would rather have their care at home. So what if we had as one of our radical redesign principles that we would always look at home first? Would it be possible to deliver this care at home? I'm thinking about things, and social care. I know how important to both my mum and my dad supported social care at home is. My dad, because he really needs it to live the kind of life that he wants to live, and my mum, because it gives her a break from being his otherwise full-time carer. The notion that he would have to receive some of that in a care home, I think would, well, I know it's scary for him. However, I think it applies. To see some of the things that can and are done in hospital at home programs. this was some of what our underlying ethos for the self-management programme was in its very early days. So I think we just need to be a bit more ambitious. I think we need to kind of push the boundaries a bit about what we mean when we talk about shifting the balance of care. Secondly, some of you might have tuned into this expecting a lot about IT and AI, and you're going to be disappointed. Because actually, look, I've no doubt that IT will play an increasing role in health and social care. I've no doubt that AI, properly directed, can and should be part of a future health and social care system. But too often, I see the dialogue about AI in particular is how can we use AI to replace nurses? Most frequently, I see that. How many nurses could we get rid of if we had artificial intelligence here? And I think that's the wrong question. The right question is, how many nurses could we enable if they had the support from AI to connect and to partner and to enhance communication. Third, I use the word seismic here deliberately. I think we need a seismic shift in the balance of power. The thing that I learned from doing the review of social care is that no one understands social care better than the people who receive it and their carers. No one. And yet their voice, the voice of the recipient of social care and the voice of the carer community is often unheard and often undervalued. And we need to do something about that. So that would be a prerequisite for me in any radical redesign of health and social care, that it needs to be truly co-designed and co-produced. I think the knowledge is power, and key to that seismic shift is going to have to be the democratization of knowledge. We're going to have to get information and support to people in a much more easily, much quicker. We need to encourage the sharing of ideas, not the putting of arms around your jotter. I've talked a bit already about this unprecedented collaboration and integration that I think is going to be required. I get really worried. We saw this, I think, a lot in the pandemic about the people who have power seeing science and experience as inconvenient for them sometimes. And we're not going to get to where we need to get to unless we recognize and respect the contribution that science and lived experience can make. Everything made easy. No more brutality in access or assessment. Everything made easy. And then I think sometimes we've lost the notion of care and what it is we're here to do. And so I'd like us to get back to that kind of fundamental, foundational root and start to think about care, not healthcare or social care, just care. One of the things we did in in the review of health and social care is we made a little video of people talking about their experiences, and I hope some of you at least saw it. But if you didn't, it's still available, and you'll hear there people talking about how what's important to them is not healthcare and social care acting separately. It's just care. I remember one lady saying to me, "I don't care about the colour of the uniform, son." I remember it mainly because she called me son, and not many people do that anymore. But you get there's something, I think, just about taking the opportunity that's provided with it to us now to do true integration, not structural necessarily, although that might be important too, but from the perspective of the person who needs support, whether it's health or social care. So those are my, what's that, 8 kind of ideas about what that radical redesign might look like. As I say, I'm 100% sure that they're wrong. I'd love us to have a conversation at some point about what the right ones are. Let's go to the next slide. I'm nearly done. You'll be delighted to hear. So the final thing that I think we need to think about is this: if we are going to make these transformations, it will need to be led differently. And I think one of the things that leaders need to be truly radical is again, back to one of the points that Sarah made earlier, is to make hope possible rather than despair convincing. We need hope now more than any other time I can recall. And at the same time, hope is not a plan. So we need hope. We need a view of the future that's compelling, and we need a plan to get there. Next slide, please. The next thing, I think, we need curiosity. We need a set of leaders who don't believe that they have all of the right answers, but who might have all of the right questions. And these are just a set of simple rules for curious leaders that myself and a bunch of colleagues have come up with. And again, if you want to read the underlying article, it's on IHI's website. Excuse me. But this idea that the future will come out of leaders who are vulnerable and see that as a strength and ask people for their ideas rather than tell them what to do. Most leaders who insist on telling people what to do have really no idea about what to do, in my experience. Next slide, 2 more to go, I think. This idea of what Father Greg Boyle calls radical kinship is really important. He describes radical kinship as a circle where no one stands outside. A circle where no one stands outside. That is what we need. That's the kind of true new narrative that will support health and social care. This is, I see someone in the thing saying, this is beyond compassion. It's beyond kindness, and because compassion still requires someone makes a choice about whether to be kind to somebody or to be compassionate to somebody. And I'm talking about something that goes beyond that. There's no need for us to make that choice because we're all in a circle where no one stands outside. No one is outside the circle. 2 more. The Pima Chaudron is the lady who Greg Boyle got some of these ideas of, and as she quite rightly says, the future is completely open, and we're writing it moment to moment. There's this fallacy that somehow the strategy is all about the future, and it's not. Strategy is about the here and now. It's about the decisions that we'll make today that will get us to where we need to get to. That's why I don't make any predictions about the future, because all that's useful, I think, is for us to create some sense of direction by the decisions that we make today. If we make a different set of decisions, we'll create a different kind of direction. And my final ask of everybody is, let's just start. I love this poem. Start now, start where you are, start with fear, start with pain, start with doubt, start with hand shaking, start with voice trembling, but start. Start and don't stop, start where you are, with what you have, just start. Sarah, back to you. Happy to take any questions that anybody has.
Oh, goodness me. Thank you so much, Derek. It's quite an emotive poem to conclude your considerations and reflections on. I find myself, when you were saying it, just actually noticing the emotion. I can see a lot of the reactions as well from people. Thank you so much for your time this morning and for sharing your thoughts, your reflections, your experience. Thank you so much to everyone who's attended and helped guide this through your questions and your comments, and for continuing to engage on these really, really, really important issues and areas of change. So we look forward to seeing many of you at the annual conference. Derek, hopefully we engage with you again in the near future. And I've really enjoyed this session. So thank you all so much.